Right, so we're going to talk about dizziness and vertigo. So this is presentation lecture 8. So with dizziness and vertigo, you need to be clear about what the patient is experiencing. So lots of people use the term dizziness, lightheaded, a bit funny. You need to determine exactly what they have. So lightheaded, giddy, woozy, fainty, that generally means that they have some postural symptoms. So if somebody feels giddy or lightheaded when they stand, if they're on lots of blood pressure medication, if they have poor oral intake, the likelihood is they're pre-syncopal, and it's a function of low blood pressure. And a lying and standing blood pressure will be very helpful there. It will not be helped by medications for vertigo or anything like that, although a lot of patients with significant postural drops on standing end up on huge doses of vertigo medication, which in turn makes their lightheadedness worse. So if somebody has vertigo, spinning, tilting, seasick, on a ship, things are coming and rocking back and forward, the world is whirling around me, I'm whirling and the world is still, that's the sort of thing that people describe. And that is true vertigo, so that's important to elicit. And then sometimes people, when they're imbalanced for some reason, which could be because they have proprioceptive problems, because their feet are numb and they can't feel their feet, or they may have intrinsic balance problems due to things like Parkinsonism, they might also use the word dizzy, but they're just liable to fall because their balance is poor. So worth asking all of those things. For proprioceptive ataxia, so if somebody's feet are numb and they keep falling over for that reason, characteristically they will fall over in the dark and they'll be much better in the light. And if they look at their feet when they walk, they are steady. If you get them to look up, but obviously hold their hands so they don't fall over, they will then struggle a bit more. Romberg's isn't really helpful if somebody is vertiginous because they're going to be unsteady anyway. So worth considering all of these things. So quite often when someone presents with dizziness, it's because they've had a fall. So try and ascertain what caused the fall. So things like, the light level, the only fall when it's dark, suggests their feet are numb and they don't know where their feet are. It's a proprioceptive problem. Loss of balance without vertigo, are they Parkinsonian? Do they have any sort of weakness in the legs? Foot drop can cause the foot to catch, and you can have a foot drop due to compression of the common perineal nerve or lots of other issues. Are they lightheaded, pre-syncopal, in which case do a lying and standing blood pressure. Some people just feel disequilibrium, so they walk steadily, their examination is normal, but they just don't feel right, yet everything on examination is quite normal. And some people can have that after a head injury or post-concussion syndrome. That can be very difficult to manage because there isn't really an avenue to treat, but sometimes physiotherapy for balance can be helpful there. So vertigo, or spinning vertigo as some people call it, you can divide that into peripheral and central causes. And if you identify that somebody has vertigo, the most important thing is trying to determine whether it's peripheral or central. So if it's ear-related or peripheral, the most common causes of benign positional paroxysmal vertigo, BPPV, so that's your little crystals that become loose in your semicircular canals. And the way to think about it is you have two little spirit levels in each ear, and you have smooth gel sort of going back and forward in the canals that allows your head to know where it is. So it kind of does that sort of thing. Now, if you end up with crystals disrupting the smooth flow in one ear, you get chaos in one spirit level and the other one's going smoothly, and your head just, I don't know where I am, and everything feels like it's spinning. Then what you need to do is maneuvers to try and get that crystal along the semicircular canal and get rid of it, generally swallowing it. And we do maneuvers for that, which I'll go into. Labyrinthitis is sort of an inner ear viral infection, usually with some tinnitus and some temporary hearing loss. Horrible to experience. I had it once. It was the worst thing I ever had it as a medical student. Takes about 6 weeks, but will gradually improve. Meniere's disease is a progressive ENT problem where people get hearing loss, dizziness, oral fullness, so the feeling that the ear is full and needs to pop, and tinnitus, and that tends to degenerate over time, but again, a peripheral problem. A central problem, We worry about things like a posterior circulation stroke. So you'd imagine it would be of sudden onset, and you would look for other things like speech and swallowing problems, limb weakness, cognition being altered. It would be very, very rare to have isolated vertigo alone as a central stroke, as a central cause as a stroke. About, I think, something like 0.2% of posterior circulation strokes just have vertigo. So it's possible, it's always possible, but it's unlikely. A structural issue like a tumour, so vestibular migraine is often suggested as a cause for dizziness. If somebody has other migrainous symptoms, so they get dizzy and then they get pounding headache, much more likely. But somebody who's got continual dizziness, I would not expect that to be migrainous. And people can get post-concussive dizziness and vertigo after a head injury. So when we think about central versus peripheral causes of dizziness, this is a little table that you can look at, but essentially you're looking at if somebody can walk, a peripheral cause is more likely. So with a central cause of vertigo, people are generally pretty disabled. Hearing loss and tinnitus, you would expect in peripheral causes. You wouldn't expect that in the majority of strokes, but again, there are always exceptions. CP angle tumours, so cerebellopontine angle tumours like schwannomas, they can cause hearing loss, but again, that's pretty rare. You wouldn't expect other neurological features like speech and swallowing problems, limb weakness in a peripheral cause, and nystagmus in a peripheral cause is generally mild, it's horizontal, it has a direction, so it beats away from the affected side. If it's BPPV, it's torsional towards the bed and it fatigues and it wears off. So people move their head, they feel the vertigo, they panic a bit, go, oh God, it's happening, and then the vertigo starts, and then it just sort of settles as the crystal settles into the canal. In central causes, it doesn't fatigue, it can be multi-directional. If it has a vertical component, it's generally central, and sometimes it can look absolutely bizarre, and we can call it saccademania, where the eyes are just bouncing all over the place, and there are very rare conditions that can cause that, or things like brainstem tumours. If you do a head impulse test where you get somebody to fix their eyes and move their head one side or the other, you can see a corrective saccade in one direction. If somebody has something like BPPV or labyrinthitis, that will push back on one side. That's what you see in a peripheral cause of vertigo. You would not see that in a central cause. And a Dix-Hall pike is a nice diagnostic manoeuvre, which I'll show you a picture of, which is positive in BPPV. And in central causes, it wouldn't be characteristic. So people might get dizzy if you move their head, but it wouldn't be just in one position on one side. So the HINTS test is a really nice little battery of examination that we do to distinguish central from peripheral causes of vertigo. We quite often use it when people are called in through A&E with sudden onset vertigo. And the question we're asked is this a stroke or is it, labyrinthitis or BPPV? So the head impulse test is the first part. So if you see a corrective little bounce of the eyes on one side, that suggests a peripheral cause. Nystagmus, so again, if you have the vertical nystagmus or bidirectional nystagmus, that suggests central rather than peripheral. And we do a test of skew where you cover one eye and then the other. And if the eye sort of corrects as you uncover, then, if it corrects when you cover, then we would expect that to be central, particularly if it's vertical. Yeah. So the HINTS test has been assessed in terms of its accuracy, and it is in the high 90s if you are an experienced practitioner in distinguishing central from peripheral nystagmus, central from peripheral vertigo. And this is the Dix-Hall pike test. So it's hard to show without a willing victim, but essentially you lie somebody down, or you sit somebody up on a bed, and you turn their head to the side, and then you quickly push them back like that. And if they have BPPV, that crystal is dislodged and you get that torsional nystagmus towards the bed, which then wears off. You then diagnose BPPV. You would expect it to be negative on the other side. And then you would do Epley manoeuvres, which is a series of movements that looks a little bit like the Dix-Hall pike test. And the idea is that you would then dislodge the crystal and allow the patient to swallow it. And people can sort of be cured instantly after the Epleys. It's really satisfying. So management. If a central cause is identified, unless it's typical of their usual migraine, and we know that it goes away with treatment, then they will need cranial imaging. So a CT if you suspect a tumour or hydrocephalus, so if they've had evolving vertigo over weeks or months, they will need a CT at least to rule out a structural lesion. If it's very sudden onset and they have other symptoms, speech, swallowing, limb weakness, they will need a CT with an angiogram looking for an embolus, a blood clot that might need thrombolysis, or for a dissection, a split in the vessel. And that is a medical emergency. So we need to do that immediately. An MRI would confirm a stroke. So a CT rules out a bleed and can sometimes see a clot in the vessel, but you might not be able to get that hyperacutely, and you need to treat stroke very quickly in the window of opportunity, which is within 4 hours. Okay, so the majority of people would have an MRI to confirm things afterwards, but you would need a CT angio in the window of opportunity for thrombolysis. If you diagnose a peripheral cause of vertigo, you treat BBPV with the Epley manoeuvre. You can also have the Semont manoeuvre or the Home-Brandt-Daroff manoeuvres, so many manoeuvres. I do quite like the manoeuvres. A sequence of head movements that would allow the crystals to move around and then hopefully down and out. Once you've done the Epley manoeuvre, you recommend that people sit up or propped up in bed when they sleep for at least 48 hours, because the danger is if they lie down flat, the crystal will slip back and they'll be back where they were before. Labyrinthitis and vestibular neuronitis, they're both sort of viral problems that cause issues with the inner ear and dizziness. But with labyrinthitis, you also have some hearing loss and sometimes tinnitus. Vestibular neuronitis, it's just the dizziness without the ear problem, without the hearing problems. It's conservative. So some people have vestibular sedatives or dizziness medicine, so cenarizine or beta-histine temporarily. And it does get better with time, but I had it for 6 weeks when I was a medical student. It was the worst thing ever. It felt like I was falling off the edge of the world. So be sympathetic if somebody has acute dizziness. Right, so summary, you need to define what the patient is suffering from. Are they lightheaded? Do they have spinning vertigo? Are they just unsteady? Do they have a tendency to fall over? Determine that first. You need to know what they have before you can then make a diagnosis. If you diagnose someone with vertigo, spinning vertigo, central versus peripheral is the next thing to determine. A head impulse test is really helpful, and if you can do the rest of the HINTS exam with the skew and the assessment of nystagmus, so much the better. If it is hyperacute and central, you need to get some imaging urgently with an angiogram, and you need to get your stroke team involved very quickly. And that's all I have to say about that. So thank you very much.